Good afternoon. Today is March 17, 2023, Friday. This is UMACO TV. My name is Kemal Erkan. As usual, this is our weekly event. And today we do have a clinical presentation, and we are going to also have discussions around our US economy and global news. Also, we have discussion on prior authorization in the primary care setting and the transparency of prior authorization that was required by law, and how Delaware is handling that and what issues that we are seeing. And Anthony Anugu is going to join me for that. So before I take too long, I'm going to invite my clinical presenters. And let's see if the mouse works fine. Everything will be just good. All right. Hey guys, how are you doing?
Good afternoon, doing well. Thank you for having me on here, Kemal.
Absolutely. So we have Joseph Alve and Donna Gunkel. Donna is our clinical director, and Joe actually is one of our new physician assistants who started at United Medical Clinic. And we are going to discuss one of the chronic illnesses in the primary care setting. These are related to the GI. But before we do that, Joe, if you can introduce yourself so that way, because this goes to our patients, so they get to know you.
Yes, of course. My name is Joseph Albe. I grew up in Atlantic City, New Jersey, and I am a new physician associate here at United Medical. Very happy to be here and very honored to be on today.
Thank you. Donna is always there when I do the clinical presentation. So what we'll do today is we are going to actually start with the formal presentation. Joe, right now you are the co-owner. You should be able to do the sharing PowerPoint. So after we finish that, we are going to have a dialogue around the GI issues in the primary care setting.
Fantastic. Okay. Let's see here. So the screen everyone sees is my screen, correct?
Not yet. So you're going to share your screen.
Okay. Okay, great. So everyone should see my screen now.
Yep.
Today, I'm going to discuss primary care gastrointestinal GI malabsorptive disorders. So what's the reason why we're having this discussion today? Well, there's been an increase in prevalence of malabsorptive disorders all over the planet, and specifically in the Western Hemisphere, that are affecting this country. And it's important that we discuss it because malabsorption as a whole can lead to disruptions in well-being. It can lead to symptoms, it can lead to psychological symptoms as well, and it's a common masquerader of certain symptoms that everyone has from day to day. So just a quick anatomy lesson here. Your GI system, specifically the small intestine, is responsible for absorption of all your vitamins and nutrients. So food is taken through the mouth, through the esophagus. It is processed in the stomach and then released through the small intestine, where a lot of your vitamins, fats, lipids, carbohydrates are absorbed and used by the body for energy. Now, this is absorbed through hair-like projections called villi off the surface of the cells that take in all of these nutrients. So what are some signs and symptoms of malabsorptive disorders? Well, we have the typical abdominal pain, stomach pain. We have constipation, diarrhea, nausea, vomiting, change in bowel habits overall, some bloating, gas, fatigue, weakness, neurological symptoms. Now, the patients could have a few of these symptoms. You could have all of these symptoms or possibly just one of them. But these are common symptoms of malabsorptive disorders. And primarily these come about because we're not absorbing the nutrients or vitamins that we would typically get if our GI system was functioning correctly. So what are tips for patients out there? The first one is a food journal. It's important for you out there, if you believe you have a malabsorptive disorder, to find your triggers or what foods can possibly cause these symptoms that I just discussed. It's important to go for preventative exams, as in your physical exam or Medicare wellness visit with your physician or provider. Screening exams like colonoscopy or possibly endoscopy can help biopsy the tissue and really learn what we're dealing with here. Also, if you have a genetic predisposition, such as a familial genetic predisposition, or someone in your family or close circle who has it, it's important to take a look at that as well. And you always want to keep the discussions open with your primary care provider. One is lactose intolerance. This is where there's a deficiency of the lactase enzyme, which does not allow it to be absorbed by the small intestine. When it's not absorbed, it goes to the large intestine, where it's broken down into a couple of gases and released as diarrhea. Here's a depiction showing that. In the top image, what you see is the lactose being digested properly by the small intestine. In the bottom image, it's not digested because of the absence of the lactase enzyme. And thus it goes to the large intestine where it's broken down into gas, diarrhea. It'll also give you abdominal pain and bloating, which is very uncomfortable, of course. Lactase is typically the supplement you take to correct a lactose intolerance malabsorption disorder. Celiac disease is the next one I want to talk about. And now we're going to dive into the autoimmune process of it. This is where when certain humans who have celiac disease digest gluten, the immune system attacks the small intestine. We can diagnose this with IgA antibodies or transglutaminase antibodies, a simple lab test. And also we can diagnose this with endoscopy and biopsy of the tissue. And this is going to be a lifelong gluten-free diet. Now, some symptoms of malabsorption with celiac disease include iron deficiency, folate, vitamin B12. These are all necessary for the production of red blood cells, and they can result in some anemias as well. Also, we have fat-soluble vitamins, which can result in many of the symptoms that I discussed related to fatigue, bloating, abdominal pain, and nausea, vomiting. What does this mean? Well, it means deficiencies because of the malabsorption, because of these disorders, can cause an array of symptoms that otherwise could be masked for other diagnoses. Another one is inflammatory bowel disease. This one is primarily fairly uncommon compared to the other two we talked about. Two specifically in this inflammatory bowel disease are Crohn's disease and ulcerative colitis. This is where we have inflammation of different parts of the GI tract, which cause malabsorption. Both typically have a bimodal age of onset from 15 to 35 and then 55 to 70 years. So patients don't have to be born with this. And what happens is the inflammation due to the immune system attacking the tissue and the bad bacteria in the intestine leads to malabsorption of many of the same vitamins, nutrients that we discussed previously. Here's just a depiction showing the small scale level of what we see. So inflammatory bowel disease, what we have happen is every food molecule, toxin, pathogenic bacteria remains in the lumen or the little canal of the intestine itself. And because of the damage and the inflammation caused to the intestine and the intestinal cells, there is no absorption of any of these vitamins, nutrients, water, minerals. This one in specific shows zinc, which is a common deficiency that we see in inflammatory bowel disease. And it could also suppress the immune system. Another one is pernicious anemia. Pernicious anemia is interesting because we usually diagnose vitamin B12 with the help of something called intrinsic factor. Well, this time with pernicious anemia, we can't digest vitamin B12 because this intrinsic factor is being attacked by antibodies. In a sense, it's an autoimmune disease in that way because we're not having the proper intrinsic factor necessary to get the adequate amount of vitamin B12. This can result in numbness, neurological symptoms, and other symptoms like fatigue, headache, and weakness. So I really want to discuss the common theme here, and that is these malabsorptive disorders altogether result in a vitamin and nutrient deficiency, which then result in systemic symptoms. And it's the central dogma to all malabsorptive disorders. They're easily recognizable, but they could be missed. Fatigue can go as far as a diagnosis of an infection or a respiratory infection, or some other diagnosis. And so it's important if we've gone down a couple avenues and you see your primary care provider and none of the treatments given to you might be working or might be doing the job, it's important to discuss this next possible step. Another one is Whipple disease. This is a bacteria found in soil and water. This is fairly uncommon, but one we still see in the primary care setting. It causes complications in the small intestine, so the one responsible for digesting the fat, carbohydrates, lipids, and all of those nutrients are necessary for energy functioning. It leads to intestinal malabsorption and extraintestinal symptoms. Sometimes you can present with rashes as well. And the diagnosis is through biopsy, and we treat it with antibiotic. And like all the other ones, we also treat it through vitamin and electrolyte replacement, depending on what we're missing. And that's why it's also important to get our baseline lab work at our physicals. Another one is fructose intolerance, and this is the one I'm going to end on today. Fructose intolerance, we have seen an array of research on it, specifically in the past 10 years, because believe it or not, 40% of people in the Western Hemisphere have it. Now, whether they're diagnosed with it or not is another fact, but fructose intolerance, especially because of processed foods, especially because of high sugary foods, sodas, and other digestible items, are being consumed and processed in factories. And so what is consisted of fructose? It's most fruits. Apples is a huge one, some vegetables, artichoke, asparagus, broccoli. Foods with wheat as the main ingredient, such as wheat bread and pasta. And many times a gluten intolerance as well can be disguised as a fructose intolerance. Sweeteners such as honey, agave nectar, and high fructose corn syrup, which I know has been a discussion in the past 20 years. And sodas and desserts sweetened with fructose as well. So this is similar to lactose, where fructose is not being digested by the intestine, and thus it results in diarrhea and an impairment in the digestion and absorption of minerals and other vitamins into the body. And so that's basically what I wanted to touch on here with malabsorption. Another one that I want to focus on, which will lead our discussion, is COVID and GI side effects, which has been increasingly prevalent within the past couple years we've started this pandemic. And so I'd like to continue and bring Kemal and Donna into that conversation.
All right. Well, Joe, thank you so much.
Yes.
It was very well. It was a very smooth presentation. Usually, PowerPoint always kind of scares me in a way that sometimes you
Right.
can lose the attention of the audience. But I think you did a really good job.
Oh, thank you.
Now, from the part that you presented, and then you had some take-home messages, and then, as you know, you were part of the our case conference process.
Right.
In the first, at least your first 2 weeks or 3 weeks. And the system that we have in place is to see what we can do from the care coordination team side to help the providers and help the patients. And then I think one main common issue that we see is not having the annual physicals scheduled properly or promptly at the right time. And usually what happens, because it's another year, so then they say, well, we'll call you, or the patient says, I don't know my schedule. Well, at some point we'll call you. And then a lot of them don't, because if there's no emergency, then they feel like they're healthy.
Right. So, and if I can interject here, Kemal, a lot of patients that I see on a daily basis, specifically related to our annual physical exam, say, oh, you know, I had a few symptoms a couple months back, but they kind of went away. They come and go, so I didn't feel as if it was necessary to come in. And it's important that you do come in and that you do have these discussions with your providers, because it could be something as simple as this, where you have symptoms of abdominal pain, nausea, vomiting, diarrhea, constipation that happen on and off that you may not have when you come in for your physical exam, or you may not have when you plan to cancel that physical exam that you might not want to come in for. But it's important to come in and to discuss these symptoms, even though they might be coming and going.
Absolutely, absolutely. And because of the, because of the physical exam, we also know that there is this regular blood work that we need to get done at least once a year. Now, I'm guilty of it, so I'm not going to pretend like it's something that we do it. When we are a patient, we are always difficult. I'm talking about myself. So, and I know I have my follow-up appointment next week with Dr. Valencia. And then now the thing is, there's a blood work that I need to complete, and I still haven't done it. But if I don't have that appointment, I won't have any pressure to complete the blood work. So now most likely tomorrow I'm going to go and get it done, or before the appointment I'll definitely get it done. So there's benefit of having these visits already scheduled, so that at least it gives you that kind of like discipline or the pressure of getting it done. So now, including myself, most patients don't communicate these issues, that we can only find them in the providers are not psychic, right? So the only way that you can find certain things, one is from the physical examination, but mainly from the test and lab work that we have, so that we can actually get a better idea. So now this month, I believe, is the colorectal month, if I'm not mistaken. And I believe the next Thursday, Dr. Sachin Nate is going to be with me on a special session just for colorectal. And one of the issues, especially for this may be more common in men, the hemorrhoid it's like a very simple issue, right? So most people don't really understand how complicated it can get, especially as you are aging. And just because sometimes patients are shy, and then they can get over-the-counter stuff, they don't communicate with the provider. But then if I do the blood work, then I'll know that if there is a problem with their hemoglobin, and then we can actually make the adjustments. And those things do change very drastically. And then sometimes it doesn't have to be, you don't have to bleed to that to see the results, right? So it's there's a fine line there where it doesn't require too much to see. But once it gets to the other side of the equation, the damage control is a lot more costly and a lot more effort that's needed and painful. So
and harder for the patient. I think that's the key, right? When we feel good, we don't think we need to do any of that. And we don't want to wait until we definitely, to your point, Kemal, till we definitely need something. So pointing out that your baseline lab work, that way the following year, if something's, gone significantly up or down, then you have a better way of gauging, right, where you were and what might be happening. Getting those preventive services. So yes, March is Colorectal Cancer Awareness Month. And I know a lot of people are nervous about getting a colonoscopy, but there are alternatives. And so at least starting with an alternative, if you feel like you would be more likely to do a Cologuard test or a FIT test, at least starting with that and then determining with your provider based on those results, then do you need something more invasive?
Well, but okay, so just because this discussion, we're not just lecturing, but we are also sharing experience. So I'll just come out and then just say that I had my colonoscopy last November, and there wasn't anything to scare, like to be afraid of. So you just go there, and I don't remember most of it anyway. So the only part that was challenging is the prep. Which actually is sometimes, like every once in a while, having those type of challenges for your body is good anyway. So honestly, that was the easiest thing to do. I think colonoscopy is less complicated than the Cologuard. Cologuard is scary. Like you have to poop in a box in your own home, and then you have to make sure that you get it. It's like too much. I didn't actually, like Dr. Valencia did order that, and I didn't do it. But last year I did my colonoscopy. So the thing is, I'm 49, and there are certain things with aging can only help us if we have the preventive precautions. So if we don't take them, then we are going to be in trouble. So I know I don't look 49, right? Donna, thank you.
You're not.
But the thing is, your body is talking, our body is talking to us in different ways. So then we have to take care of it. So before it's too late, we really need to make sure that get your physical exam scheduled and then get your blood work done. Now, while we were getting ready for this, as Joe was telling us earlier, so there's this new study came out, and I find it very interesting because it was just timed for this this event, this episode.
Right.
So COVID and GI and the number of people who were participating in this, it's about 154,000 people in the 5.6 million control group. or the control group is 154, and then they compare with the people who didn't have COVID. So this study is from March 2020 to January 2021. If they had COVID and if they survived COVID in the first 30 days. So I'm one of those people. So like it was end of March, and then I survived COVID. But the interesting fact is patients in that group who had COVID, they are overall GI disorder were 36% more likely in that group than those who didn't have. So I find that very interesting. And, Joe, I don't know if you can kind of elaborate that a little bit to see what would be the main reason, or do we know if what is the actual reason for that connection?
Of course. So a lot of people don't realize when we have viral infections in general, which COVID is a virus itself, a virus is going to infect everywhere in the body. It's a systemic thing. And so COVID specifically can act as a reservoir in the intestine itself. So COVID can make its home in the intestine and cause a lot of problems with the intestinal cells, and also lead to malabsorption like I was talking about, but lead to other things as well, like stomach pain, nausea, vomiting. It can also get into the heart and cause heart defects. It can get into the brain. We're seeing long COVID, which is a longer diagnosis of COVID and having more severe symptoms of COVID, affect the brain as well and cause early onset dementia. We're seeing it with delirium as well. A virus will affect the systemic portion of a being. So everywhere you can think of, a virus is going to go. And that's the same for COVID. Unfortunately, COVID does its worst damage in the lungs itself and the pulmonary system, but it doesn't stop itself there. And so that's why a lot of the times, actually, we see COVID with GI symptoms. And it was really interesting because when I was a student about a year and a half back, I was seeing COVID present with one of the variants, I forget which one in specific, primarily as abdominal pain to begin with. These patients would come in and say, I had nausea for a couple hours the other night, and I don't know where it came from. It wasn't associated with eating or any other symptoms. And, someone around me was sick with COVID, but I wasn't really near them. And then 2 days later, it progresses to pulmonary manifestations. That's your cough. That's your wheezing. That's your shortness of breath. So I've seen a lot of patients start with abdominal pain, and you can't rule out COVID when you have abdominal pain, especially as a start.
So I think that connection is very interesting. And I know you did see some of our Bariatric Friday events, and Dr. Rida we do discuss a lot of issues around morbid obesity. But I think it was just last week that we were discussing how our stomach actually is communicating with the brain, and then when there is a damage or there's a virus, the communication is actually affected by that as well, affected by that. And it becomes a lot more complicated. Now, when I read that, actually, I personally had some issues on the GI side lately, and at least I can speak for myself, during the COVID, most people did gain weight just because we didn't do our routine stuff. And it doesn't surprise me that GI problems start with right after that. I can see, I don't know exactly why, but it makes a lot of sense to see that. So because of all those reasons, we want to make sure that patients do come and see you guys. And then they also do a lot of reading, because the only thing is that when they try to treat themselves versus they read for education, that's kind of like the fine line, because I see a lot of patients who are trying to, so I'm not going to lie again. So I do maybe that too as well. So let's not just put the blame on.
Don't we all?
we all do, right? We are trying, I have this problem. Let me see what's happening here. But that should be really just for education, to have a better discussion with your provider. Should not replace your provider, because how I'm interpreting that information, what I'm reading versus how Joe can do that is different, because he had the right education for that. So he's going to have the right tools and right decisions for the patient. So that's really important from that point. So Donna, anything you wanted to add?
Well, in the article, Kemal, and I didn't really think about that, but as you know, I had COVID last year. But it does make you kind of think back to things. And then, without knowing these, did you assume it was something else, right? Was it something I ate? Was it some other cause? But I guess I was surprised when I read this that it said, compared to the control group, patients who had the virus were 54% more likely to suffer irritable bowel syndrome, which is a significantly high number. 47% were more likely to experience inflammation of the stomach lining, and 36% more likely to have an upset stomach without an obvious cause. So again, putting that out there so people do think about it, and not just say, oh, it was related to that. But again, another reason that you should see your provider so you can determine, right, is it something more serious, a more chronic problem? Is it something that was, a one-time thing? Was it related to a food I ate or something of that nature? I think we all tend, well, at least speaking for myself, I know a lot of times I tend to think, it's nothing serious. I'm sure it was just this that I ate, or I haven't had that for a while, or it was this, or a combination of things. So I think it's just important to make sure that you do discuss those things with your doctor and you do go in, to be seen, if not right at that particular time, but making sure you do get your physical, which I'm guilty of too, because I had mine scheduled and then with other life events, I had to cancel it. So I too need to do that. Full disclosure here.
What I always say to patients is, I'd rather you be safe than sorry. I'd rather evaluate you, have you come in, do a physical exam on you and any other tests that I need to, and make sure that you're okay, rather than let something like this build up and then have to face the repercussions afterwards. Like you said, Donna, it's pretty astonishing seeing the percentage of heightened risk for these GI problems with people who had COVID. And this isn't even severe COVID. This is mild COVID, and many people present with mild infections of COVID. So it's a predisposing factor for sure.
Well, Joe, thank you so much. This is really important when our providers are able to join us and be part of these discussions, because we do communicate and we try to send these to our patients for more education and more support. So thank you for being with us today. Donna, as usual, thank you for joining us. So we'll continue with the rest of the session. All right, thank you guys.
Thank you for having me.
Thank you.
All right, so now Sean Donovan is off today. So, and I have Anthony Onugu helping me with the dialogue for the rest of the topics that we have. So, Anthony, how are you doing?
Hi, Kemal. I'm good. How are you doing?
Good. So, this was a really useful, interesting education that we got on the GI. Joe did a really good job explaining it in simple terms. Sometimes when providers do something, so it's difficult to follow. So, but I was able to pay attention. So we have a couple of different topics today, and thank you for joining me first. And our Bariatric Friday most likely is, I'm saying most likely because Dr. Erkan may be tied up, but I don't know yet. So right now he's still on the schedule. So we wanted to discuss, just to be mindful of the time, I want to bring our main topic that you actually wanted to elaborate more, this Prior Authorization Act, I guess, right? This was a bill. So I'm going to actually bring that up. So if you can give us the background on this, and then we'll discuss why we are even talking about it, and then what our plan of action is for the future.
Yes. Yeah. Thanks for having me. Most of us who have been patients have at one point in time or the other come across a requirement from an insurance company to have either a procedure or a test or an imaging requirement to be subject to prior authorization by the insurance company before you're able to get that service. And the original intent of that was to control overutilization of services, unnecessary services. But at the same time, in terms of its implementation, it's created undue burden on the patients, on the providers, even on the insurance companies in a sense, because of the additional administrative structures they have to put in place to oversee this requirement. So we have all manner of individual stories from patients. A case of someone who has a cancer that wasn't approved in time. And you have multiple stories over the years. The state of Delaware, on its part, had taken a crack at this as far back as 2016. And I believe under House Bill 381 in the 148 General Assembly passed a bill then to regulate prior authorization. But the 2016 is what is it now? 7 years behind us, and a lot of things have happened since then. And among the provisions of that bill was you had a timeline for approval of a prior authorization request, 5 days if it's electronic, 8 days if it's paper-based. And it has a transparency provision, but that transparency provision just required the insurance companies to annually report data on prior authorization, sort of send the reports to the Delaware Health Information Network. That's what was considered.
So, Anthony, I just want to make sure that people are able to follow us. I'm going to ask you just to kind of clear a couple of the things. Now, prior authorization is required by the patient's insurance plan, right? So, so then, is this the goal for this one? Is to standardize what prior authorization is needed for what services, or is it, if it's denied, what reasons it would be denied for?
The entire proposal is designed to standardize the process, right? And through that mechanism to create essentially a 5-day timeline for a request to be resolved one way or the other. And crucially, what it does is create an API, which, as you know, allows for multiple softwares to be able to interface with it. It makes the insurance companies, right, to use an API platform to manage the prior authorization process for Medicaid, for the children's health insurance, for Medicare Advantage plans. It requires all of them. As you can see from the graphic there, what essentially it does is create a workflow from the provider side to the insurance side and in reverse and back the other way, and creates a standard for what will be electronic or digital signatures, and as well as a mechanism for even the patients, right, through their patient portals to be able to get information on the progress of the request. So in standardizing that, it solves some of the major problems you have. A practice like United Medical Clinics, like our UMC, that's a large primary care practice with a fairly strong front office, is able to navigate this process easier than a small primary care practice with just a few staff in the front office, or even a small gastro practice that's trying to get an approval for a procedure. Just this week, I believe United Healthcare is requiring that all gastroendoscopies be subject to prior authorization effective June 1. Now, so you have a situation where you manage an ASC. So you have a patient who has a fairly urgent need for service. And if there is a delay in the process, such a patient could, in theory, end up in the emergency room. So it becomes a case of penny wise, pound foolish, right? So standardizing the process now allows every stakeholder in this, from the provider to the insurance company, to have a standardized process through which the request can be put in, the utilization review can happen, and the results can be transmitted back to both the provider as well as the patient within that 5-day timeline. There's been some criticism that 5 days might be a bit too long, but certainly the most important part of this is that process, that standardized process that it seeks to create.
So let me ask you this. So you mentioned earlier, I own a surgery center, and I was not really clearly informed by this process because I don't know how it's being used and how it's going to be, where I can get this information, what that information actually tells me. So you mentioned this is about like 7 years now, right?
Yeah.
So I think most providers and facilities, maybe they don't even know this is happening, but also how it's happening is where I think our issue is.
Yeah.
So, and this goes through the Delaware Health Information Network system, but what goes through that, I don't know.
Yeah, nobody really, I mean, it's just a provision in that bill that they provide annual reports. In other words, they send a report of every prior authorization review at the end of the year. So there's very limited value that has, because it doesn't make the process faster by doing that reporting. It creates a burden on the insurance company without any real time value that helps improve the process of either making the request or getting the information back.
So it's not so far, it's not so useful.
Yes, so far.
Now, the reason we wanted to discuss is because the purpose of this wasn't that it wasn't going to be useful. The purpose of this is that we can actually improve the process and also see who has more problems than the others, which insurance versus, like insurance A versus insurance B. That report is not available, I don't believe. At least I don't have one. Now, it's not just a surgery center that we have, but we own medical practices. We run an ACO, and we don't have any data or information that's given to us regarding this. So now, obviously, we want to know more, and we wanted to introduce this issue and then better understand what the purpose was. So who introduced the bill again?
The bill was sponsored by Representative Bombach and Senator Henry, who I believe is no longer in the state Senate. We've sent an email out to Representative Bombach asking him.
So we want him to come to the show and then have a discussion with us and maybe answer the questions. And maybe he's not aware of the problem either, right? So
quite possibly 7 years since.
How can they even know what it is that this was going to do? This was going to do if they were not working in the healthcare setting anyway.
Yeah.
So
and I noticed that the committee chairs for both the House and the Senate have long since changed since he was the sponsor of that bill. So a lot of changes. 7 years is a long time.
Now, what's Din's responsibility in that, in terms of the reporting?
The bill only really, the law only really makes provisions for them to receive that report. On their website, there's no indication of any particular portal within it through which you can access that report. It's unclear to me what the data is being used for. If they have indeed received those annual reports faithfully over the years, that part is also not clear. So it's that's before you get into the discussion of what the real value of such reports is in the first place.
So just so that people can have a good, maybe we can put this in a good perspective, I'm going to just share one thing here. Let me see if I can do that without jeopardizing any HIPAA issue, getting into any HIPAA, and this is, yeah. So, as you know, the bariatric surgery, like you were talking about, like endoscopies, but like, let's look at the, just from one view of bariatric surgery, what patient has to go through. And you can see the screen. So what we see here is, in order to get the procedure done, like before we send it for the prior authorization, so patient needs to get initial visit for cardio. They need to get an echo. So then cardiologists can do a better decision. So both may require either referral or authorization. The echo definitely requires authorization, but this needs a referral. So then they need to get an EGD, requires an authorization. Then they need to get a psych, may not need any authorization or referral. So then they need to, psych. So then they need to get a MD clearance, and they need to get a surgical clearance. And then in the meantime, this patient is already on CPAP, meaning that their sleep apnea is treated. If they were not on CPAP, then we would start the pulmonary, which would require another referral. And then getting the CPAP itself is another authorization. So that's before the surgeon, before the surgery.
Before the surgery, yes.
So then we have also like about 3 to 6 nutrition on the other window. So, and then boom, you have like at least 3-4 different referrals, and then maybe 3-4 different authorizations before you can actually apply for the authorization of the surgery. So that's the system that we are going through. And many patients don't understand how complicated this is. And in most cases, they do blame their primary care physicians for the reason being. But the reason is because primary care needs to manage all those. And then if there's no standard, like in terms of the time that it takes and what's required and all that, then everyone is wasting a lot of time. So now, again, going back to our goal here is we invited the state officials to be part of the discussion and then see if we can actually improve what's in place already in the state of Delaware regarding the prior authorization, as we believe that it is not effective, useful, and it's not being utilized.
Yes, it's not. It's not helping anyone. All of those processes you just identified, this is for an ASC that is fairly well established. Now, imagine how this would play out on a different medical issue in a small primary care practice, and having to do that not just for one insurance company, but for multiple insurance companies, each one with its own process, right? Yeah, so it's the CMS proposal doesn't impact, as you know, anything commercial, right? So it leaves a huge gap still in the process, and it's not expected to become effective until 2026. So that is 3 years removed from today.
So there's this always like waiting until the last minute of these, but I think we can probably engage this discussion, engage the discussion earlier, engage the parties for the discussion earlier, so that they can actually. One of the reasons that I believe what we are doing right now is important, and that's why we keep doing it, is because it's our one of our communication tool. so that they're able to reach out to the state officials and other parties. Now, I want to give you another interesting background on one of the insurance problems that we have. One of the Medicaid managed care organization is not letting the specialists to bill level 5 new patient visit. Don't get nervous. I won't name them. So I know that always makes you guys nervous for whatever reason. But one of the two, now there are three, but it's from 2022, and it's still continues. So the problem is, they say, well, because you have billed more than peer in the area on the in terms of the level 4 to level 5. So before we pay, you have to send your note, and then we'll decide whether or not we'll pay you. So that's even more than the authorization itself.
Yeah.
And we are fighting right now to get them understand, but they're actually not listening, which we are going to have a discussion with Medicaid at this point. The problem is this. So the statistic that they have is based on, like, just think about this, everyone is in one classroom, and you have dumb kids, and then you have really smart kids. Smart kids are being penalized for being good because average is so low, so why are you so good? Okay?
Yeah.
So now, let's talk about bariatric. How many bariatric surgeons in Delaware you have that you can compare me to? And the ones you are comparing me to are junior, very like fresh junior. They're at least 15 years behind, and they have no idea about the coding. So if they don't do the proper coding, your statistic doesn't give you a good average. Yeah. And then now you are being penalized for doing it right. So now I would understand if someone takes my note after they pay us and I say, look, you're not billing this right. And then here's our 100 notes that we audited. So this is what we have to do. No, they didn't do that. They stopped paying until we send the note. So first we have to get the rejection. Then they send the request for a note. And then the note doesn't actually, once we send the medical notes, medical records, if they are not on the same page and if they don't agree with what we bill, they don't tell us exactly what we miss. They don't. It's very vague. So it can be this, it can be that. So now here's the interesting thing. So we have two very similar notes, and then they pay one, they don't pay one. So, so this is also happening at the Medicaid level right now. So, many people don't really understand, like, this is the only industry where you don't get paid when you are providing the service. So it takes, in some cases, months and months and months to get paid. Yeah. So that's why this discussion is important. And I just want to make sure that when we have these state officials, we can get the most out of them, maybe include that discussion as well. But I know that we are going to discuss this with Medicaid. Yeah. So, Anthony, we had, before Sean went for the, today is the St. Patrick's Day, right? So before he went for that, I'm sure he's watching right now, maybe not. So he did prep a lot of stuff for us. In terms of the time, we are a little bit limited, but I do want to cover the banking issue, and because this becomes really problematic for everyone. It's not just the banks are going down, but people who may be doing businesses who may be doing business with these banks, we are all a little bit nervous. So just to kind of give the background, what happened in the last 9 days or 8 days, one of the biggest banks, number 16, went under. And then another bank right after that also had a similar issue. And the third one was the day before yesterday. So there are now 3. Now, I don't know if there's another one this morning. So I know that there are 3 of them so far. And the number 1 and number 2 are the second and the third biggest in the US history. So one thing that we keep talking and then I have all my notes from prior to from the prior events. For those who may not know what we are doing, so I keep them all. And then when the Feds are increasing the interest rates, what may be happening? And then this doesn't say clearly, well, this also could have happened, but it does, like when you read the between lines, then you can clearly see that this was on our way, because when the banks who have a lot of deposits, when they invest those in the secure funds, and when there's a huge change on the interest rates, then you have the perfect storm. And then when there's the little crisis, like little panic, that creates a huge crisis, which is what happened in these cases. Anthony, I don't know if you want to add anything.
Yeah, you're absolutely right. It's the financial equivalent of the healthcare movie Contagion, and what's really interesting about the Silicon Valley Bank from a healthcare perspective is that it's been the banker for venture capital based technology startups, health care startups, especially the digital health companies. You know that as a result of the pandemic, there was a huge inflow of capital for all sorts of digital therapeutics, digital therapeutic companies, and so on and so forth. And these were likely being banked by SVB rather. And I think about a year ago, they did announce that they were banking for at least half of all those VC-based.
The Silicon Valley, yeah.
Yeah. So the potential impact of this essentially was really what was troubling, and which led, I imagine, the Feds to intervene in the manner in which they did. On one hand, though, you could blame the bank itself, those regional banks, for the decisions that they made, because not every regional bank is being, even though now with panic in the system, it's hard to tell which one is next, but
these are specialty banks, right?
Yeah,
So
they're
they're not
banks,
like
right.
our regular, they're not like the WSFS,
Yeah.
GSCs, or Bank of America's, but they're specialty banks.
Yes, and now what you're having is a move away from some of these banks in the direction of the bigger banks, in order for people's money to be in more secure hands. But then there's a reason why some of these banks thrived in the first place, because they were essentially bridge financiers and providing short to medium-term capital that the bigger banks were not necessarily disposed to provide. So it does have implications well beyond the immediate scope of some of those banks. They may not be the biggest banks, but they have footprints in both the financial and the healthcare side of the healthcare financing side of this that makes the situation quite dicey. It seemed like the stocks of those regional banks started to rise, appreciate, with the big banks coming in to bail out. I think it's called is it the first?
First one.
Not the SVP, but I think the name is First. Struggling to remember the name of it now. But one of the 5 major banks did bail out one of them, which led to appreciation of the stocks of those regional banks. But today it's since gone in the other direction, because there's still a lack of clarity about who's going to be next. As you mentioned, it started with 1, then it was 2, and 3, then we have Credit Suisse in Europe also for different reasons.
One of the Swiss
also,
banks.
also, yeah. Mm.
The thing, Anthony, with these, there's another thing, and I don't want to actually speculate that too much, but I think the way that the financial discipline also was kind of lacking with some of these banks. So how they're actually spending the money, where they're spending the money, what they're promoting, what they're supporting. There's this woke agenda was kind of on the target now. What they're actually really promoting, because the bank is extremely powerful, right? So because of the system has changed so long ago, so they don't need to keep anything almost in their reserves to lend money. So they are using some intangible to make a lot of money. Intangible meaning is that when we borrow, let's say $10 million from the bank doesn't have $10 million. They used to have at least $1 million for each 10 unit, but that's no longer the case anymore. So therefore, when there is a demand of the deposits, when people want to get their money back, there is not enough money. Everyone knows that. Yeah. Like you may think that you have like $5 million in the bank, but you don't. If you go to the bank, if the bank is not able to, maybe if you are the first 10, they will give you $5 million. But if 100 people are asking that $5 million at the same time, they will go bankruptcy. So that's simple. So, and everyone needs to know that, right? And that's why I think the regulation for the banking is important, and then how they are being audited is important, and it needs to be more transparent, because we got nervous. So because we do business, right? What happens if you are not able to access your money? How are you going to do the payroll? How are you going to, pay your bills? So it's kind of like personally, it's making me nervous. Now, the only advantage we have is we are, as United States, we are the US dollar is the global reserve money. So, we have a little bit better control, but any other country who are depending on the dollar, they are screwed. So, now, the funny thing is, and then I will tie it up there. So, as soon as this banking happened, and then there's a drone in Black Sea that's shut down by the Russians, and all of a sudden everyone is like, "Oh, there's something else is happening. Don't worry about what's happening with the banking." And the stupid drone is just a drone, right? There's no one in it. It's in the Black Sea. It's about 6,000 miles, I guess, from here, or maybe 6,000 kilometers. I don't remember. So I should know that. But then, boom! Like there's some entertainment available if you are taking the banking too seriously. So we are going to start a serious discussion with Dr. Erkan. I don't know if he's already there, but Anthony, thank you so much for joining me today. And then we'll continue the discussion with the state officials on the prior authorization bill. Thank you so much. And thank you for everyone joining us.